Let us talk about the management of hepatorenal syndrome. These are my acknowledgements. Please take time to read this notice. So whenever you see a patient with cirrhosis and ascites admitted to the hospital for whatever reason, bleed, encephalopathy, infection, etc., you make sure that you follow the patient's kidney function closely. If the creatinine increases by more than 0.3 milligrams per deciliter within 48 hours, or if there was a 50% increase from baseline that was recorded within the last 7 days, you suspect or make a diagnosis of acute kidney injury. Depending upon the serum creatinine level, increase from baseline less than twofold is stage 1, 2 to 3-fold is stage 2, more than threefold from baseline is stage 3 acute kidney injury. It is important to establish the diagnosis of hepatorenal syndrome before you could consider vasoconstrictor therapy, terlipressin or norepinephrine. So how do you establish diagnosis of hepatorenal syndrome? You need to rule out other pre-renal causes of hypovolemia. You need to rule out renal causes and post-renal causes. And then you boil down to pre-renal hypoperfusion due to renal vasoconstriction. That is hepatorenal syndrome. So you take the history and examine the patient. Make sure there is no shock, there is no exposure to nephrotoxic agents, and you've given volume expansion after stopping diuretics, intravenous albumin, 1 gram per kilogram for 2 days. Even then, the creatinine doesn't budge. You've examined the urine for protein, and you've examined the urine under a microscope for RBCs. There's no proteinuria, there's no hematuria, and the sediment is okay. Then you say there is no nephropathy. You also do an ultrasound to rule out obstruction. And then you look at the fractional excretion of sodium, less than 0.1%, and fractional excretion of urea, less than 21%. When you put all of these things together, you make a diagnosis of hepatorenal syndrome. And the treatment is albumin to expand the extracellular the blood volume, and vasoconstrictor therapy to increase the mean arterial pressure to perfuse the kidney better. Recently, terlipressin has been approved by the FDA, and it is approved for acute kidney injury in patients with cirrhosis where the diagnosis of hepatorenal syndrome has been established. You cannot use terlipressin for acute kidney injury from hypovolemia. You cannot use terlipressin for acute kidney injury from renal causes like acute tubular necrosis, acute interstitial nephritis, or acute glomerular nephritis. And you cannot use terlipressin for obstruction. So it's important to establish the diagnosis of hepatorenal syndrome. And then that patient has to be listed for liver transplant, either already listed or going to be listed before you start terlipressin. Because terlipressin has its own serious side effects. We're going to look at that. So when it comes to terlipressin, you can also tell the patient whether he's going to get better or not, and in which patients it is basically not a good idea to start terlipressin. Obviously, advanced renal disease, if they have a serum creatinine of more than 5 milligrams per deciliter, hold off terlipressin. Advanced liver disease, especially in patients with acute and chronic liver failure, 3, or MELD score of 39 or more, again, hold off on giving terlipressin. If the patient has respiratory failure with breathing difficulties, low oxygen saturation, in this case, you may want to wait till that respiratory status gets better. Until that time, hold off on terlipressin. And say, for example, you have found that the patient has HRS, AKI, listed for transplant, and you don't have advanced liver disease, don't have advanced kidney disease in that patient, and you don't see any respiratory difficulty, you decide to start the treatment. What is it that you should advise the patient and the nurse at the bedside to keep monitoring? One should monitor for ischemic symptoms and signs. Ischemia of acral parts, because these patients can develop gangrene of fingertips, toes because of severe vasoconstriction, tongue, and they can develop ischemia of the bowel. So, patient complaining of abdominal pain, you have to be careful. Cardiac ischemia is another one to keep in mind. In patients that are treated with terlipressin, because it's a vasoconstrictor, it produces an increased afterload, and then you're trying to give intravenous albumin, which increases the preload on the heart. And if the heart is a little bit weak with increased afterload and preload, it could precipitate pulmonary edema. So you have to be monitoring for all these different setbacks, and these patients should be constantly uh, monitored with continuous pulse oximetry. And the nurse at the bedside should be vigilant about these setbacks. So, important to educate the nurse, important to educate the patient and the family. So, once you start treatment, you monitor the patient, and we'll talk about the regimens that people have recommended. When do you stop treatment? If the patient responds to treatment with improvement of the kidney function, and you also stop treatment if the patient doesn't respond despite getting to the maximum tolerated dose and continuing it for 2 to 4 days after reaching that maximum tolerated dose. And we'll come to the maximum dose, and the maximum tolerated is if the patient develops side effects, you may have to back off. So the FDA recommended to FDA approved terlipressin as a bolus dosing, but experts feel that infusion is better because of better safety profile. Because the terlipressin has a short half-life, and if you give every 6 hours with a half-life of duration of action of 3 hours, you're going to miss out something. So we're going to talk about between the bolus and the infusion treatments. I'm going to discuss infusion treatment. If you want to look at bolus, you can refer to articles that talk about how to give bolus of terlipressin. When it comes to infusion, we will take two cases. One case where you gave the treatment, took the patient to the maximum dose or maximum tolerated dose, and the kidney function did not budge. What do you do then? So here is a patient who has not responded. You start on day 0. His serum creatinine is 3 milligrams per deciliter. You start with 2 milligrams per day of terlipressin continuous infusion. And then 2 days later, uh, the serum creatinine is still the same. You increase the dose to 4 milligrams per deciliter. And then day 4, no change in the creatinine, as you can see. 3 milligrams baseline, labs today, January 6, day 4, 3 milligrams serum creatinine. Then you increase the dose to 6 milligrams per day. And then you go to day 6, serum creatinine budged a little bit down from 3 to 2.9. Not great. So you increase the dose to 8 milligrams per day. Continue the therapy, and then you come to day 8. Still, the serum creatinine is stuck at 2.9 milligrams per deciliter. We started with a baseline of 3 milligrams per deciliter. So what do? You increase the dose to 10 milligrams per day. And then on day 10, the serum creatinine budged a little bit down, 2.7 milligrams per deciliter. Can't say that it met the criteria for response. So you increase the dose to 12 milligrams per deciliter. Then basically you reach the maximum dose of 12 milligrams per deciliter, and you continue the dose on day 12. Day 12 is 2.7, creatinine of 2.7 milligrams, not budged that much. You can't say that it met the criteria for response. You continue the dose of 12 milligrams per deciliter, and then continue for 2 more days. On day 14, serum creatinine came to 2.6. If you calculate, did it reach the response rate of 20 to 30%? No. And then you define this as no response to terlipressin therapy, and then you stop therapy. Once you stop therapy and you define this patient as a non-responder to volume expansion and vasoconstrictor therapy, what do you do for this non-responder? You should, because the patient is on transplant list, you want to start them on renal replacement therapy and try to get him to liver transplant. And there is also discussion about whether you should do liver or liver plus kidney transplant. And those things you may want to check out and read the original articles. So now let us take another example. Here is a patient who is lucky, who responded to therapy. Unlike the previous patient, his serum creatinine is not 3, it is 2. And we know that when you start therapy with a lower level of creatinine, they are likely to respond. Higher creatinine is a bad prognostic factor. So we start the terlipressin infusion, day 0, baseline creatinine 2 milligrams per deciliter. We start with 2 milligrams per day of terlipressin infusion, and then day 2, serum creatinine didn't budge. Increase the dose to 4 milligrams per deciliter. Then day 4, creatinine came down by 0.1 milligrams from 2 milligrams, 1.9 milligrams per deciliter. You can say no response. So increase to 6 milligrams per day of terlipressin infusion. Continue. And then by day 6, it looks like the creatinine is budging down. Now 1.7 milligrams per deciliter from a baseline of 2. Then you increase the dose to 8 milligrams per day of terlipressin infusion. And then what's happening? The creatinine came down to 1.5. It reached the target for defining response by day 8. And you continue at 10 milligrams per deciliter, and you say that it responded, and then you stop treatment and continue monitoring the patient, because these patients can develop relapse. So you need to closely monitor these patients. And once they get better of hepatorenal syndrome, they are likely to relapse. So these patients should also be on the transplant list and taken care of. So we talked about the diagnosis of hepatorenal syndrome. We talked about combination of volume expansion with IV albumin and intravenous terlipressin infusion, and bolus is what is approved by FDA. Infusion is what most experts recommend because of better safety profile, better effect. And you start with 2 milligrams, increase by 2 milligrams every 2 days to a maximum of 12 milligrams per day. In the process, you monitor closely for respiratory distress and ischemic complications. You also follow and see whether the kidney function is improving by closely following the serum creatinine. It should drop by at least 25% from the baseline. I hope, and if in case as you're doing this, if the patient gets into respiratory distress, um, you should consider cutting down the albumin infusion. Continue the therapy. If the patient develops setbacks with the ischemia, you may have to hold off on the terlipressin. Uh, and I've used these two articles to summarize this for you. Both are excellent articles, and thank you.